Thanks, Shannon. Next presentation is by Dr. Lakshmi from Medicine 3 to Heritable Brothers.
Good morning, everyone. I am presenting on behalf of Medicine 3. Two brothers, Mr. AK, 33 years, and Mr. RK. AK is elder brother and RK is younger brother, 23 years, presented with the complaints of swelling over the back of both ankle and pain over the back of both ankle for initial swelling over the back of both ankle for 28 years, Mr. AK, and swelling over the back of the both ankle for 18 years, Mr. Harke, and then pain over the both back of both legs for the 5 years, and pain over the back of both legs for 5 years. So detailed history, first AK. He developed swelling over the back of both ankle at the age of 5. Initially it was smaller in size, then progressively increasing over the past for 28 years. And for the past 5 years, it was associated with the stretching type of pain and a difficulty in walking with pain. And around 5 years of the age, he stopped going to school also due to poor understanding power. And in early adolescent, the patient is used to have excessive anger and easy irritability. In the late adolescent, the patient has, as per mother history, the patient has a memory loss and aggression and inappropriate laughter. And now the patient currently depend on the mother for day-to-day activities. Mr. RK also developed swelling at the age of 5. It was also initially smaller in size, progressively increasing for next 18 years, and it is also associated with the stretching type of pain for the last 5 years. Around 7 years of age, it stopped schooling because of poor scholastic performance. And he also in early adolescent got excessive anger and easy irritability. In adult, he is also experiencing memory loss and difficulty in riding bicycle. But he can do his own activities. He can understand our comments. So on examinations for both vitals are stable, and we find xanthoma over the tendon, xanthoma swelling over the tendons.
Yeah, once we finish, maybe we can go outside. We're not allowed to bring the patients inside.
Over the both ankles. So systemic examinations, we found a CNS system examination for the elder brother. A mini mental status examination was only 9. So and the patient is in ataxic gait and reflexes are 3+, but other system like sensor system, motor system, cranial nervous system not assessed because patient is not understanding our comments. And then other system examinations was normal. For younger brother, CNS system mini mental status examination was 12, and the ataxic gait is there, and the patient cerebellar system examination revealed intentional tremors, finger nose chest impact, and tandem walking impact. And the sensory system, motor system, cranial nervous system is normal. Other system examinations are normal. So my case summary for 33 years and 23 years, both are to hold two brothers presented with the tendon xanthoma over the Achilles tendon and progressive cognitive impairment, and one has cerebellar signs. So the probable diagnosis. So yes, sir. One more clue is 3 weeks back we presented from the medicine unit 3, we presented a similar case. So before coming to diagnosis, I proceed with approach to xanthoma. So approach to xanthoma, there are 5 types of xanthomas: eruptive xanthoma, tuberous xanthoma, tendinous xanthoma, plain xanthoma, verruciform xanthoma. Because our patient presented with the primary complaints of xanthoma, so we approached with the approach to xanthoma. So the eruptive xanthoma means 1 to 5 mm of erythematous to yellow papules appear in crops. So it most common site over the extensor surface of the extremities, and then Tuberous xanthoma is yellow, orange, or erythematous papule or nodule located over the joint or extensor surface of extremities, such as elbow and knee. Tendinous xanthoma, skin-colored mobile nodule over the tendon or ligament, most common Achilles tendon. Plain xanthoma, yellow thin plaques on the eyelid, neck, trunk, shoulders, or axilla. And verruciform xanthoma, verruciform papules in the oral cavity or anogenital skin. So once you find the xanthoma, if it is eruptive, then we have to order a fasting lipid profile. If it is elevated in eruptive xanthoma, then we can consider the diagnosis of hypercholesterolemia type 1, type 4, and type 5. If it is not, if a fasting lipid profile is not deranged, then we can reconsider our diagnosis. And in tuberous or tuberoeruptive xanthoma, again we have to first check a fasting lipid profile. If it deranged, then we can consider suspect hypercholesterolemia type 2 or type 3. And then tendinous xanthoma, we have to check FLP is elevated, then it comes under type 2 hypercholesterolemia. If a fasting lipid profile is normal, then we can consider two other diagnoses, that is cerebrotendinous xanthomatosis and cytosterolemia. And then plain xanthoma seen in homozygous familial hypercholesterolemia, familial dysbeta lipoproteinemia, and malignancy. Our patient has skin-colored nodule over the Achilles tendon, so we consider that as a tendon xanthoma. And then we proceed with the FLP. FLP showed a normal. Fasting lipid profile was normal for both brothers. Triglycerides 178, serum triglycerides is 123, and then 130. LDL is 106, and for younger brother is 74. So we thought the two diseases, cerebrotendinous xanthomatosis and cytosterolemia. But the difference between the two primary things is CNS cognitive dysfunction. CNS involvement is commonly seen in cerebrotendinous xanthomatosis, but in cytosterolemia, no CNS involvement. So we consider clinical diagnosis of cerebrotendinous xanthomatosis. So cerebrotendinous xanthomatosis, it is a rare autosomal recessive disorder because of variant in the CYP27A1 gene. So here the primary pathology is the chenodeoxycholic acid and cholic acid is not produced. But instead of that, the cholesterol, the bile acid intermediates will produce. These intermediates is toxic to our neurons. It will cross the blood-brain barrier, and it causes the following symptoms. In infants, it causes chronic diarrhea, and then cholestatic liver disease and infantile spasms. In the adolescents, developmental delay. In adolescents, cataracts, and then followed by cognitive impairment, then seizures, tremors, spasticity, xanthomas, atherosclerosis, osteoporosis, hypothyroidism. So this is a study done in 43 cases with the cerebrotendinous xanthoma. They found 81% presented with neurological disease, 77% presented with the tendon xanthoma, 74% presented with the cognitive impairment, and 70% presented with the premature cataract, and 53% presented with the chronic diarrhea. So this study concluded that if a young patient presented with a tendon xanthoma and a relatively normal cholesterol level, especially those with cataract or any learning difficulty, should consider a diagnosis of cerebrotendinous xanthomatosis. And then there is also one study for the showing effect of a chenodeoxycholic acid in 17 patients with the cerebrotendinous xanthomatosis. They treated 17 patients with a chenodeoxycholic acid of dose 750 mg once a day. They found dementia cleared in 10 out of 13 patients. Pyramidal tract and cerebellar signs cleared in 5 patients. EEG abnormalities resolved in 5 out of 10 patients. Cerebral CT scans improved in 7 patients. And cerebellar xanthoma disappeared in 1 patient. So in our patient also, fasting lipid profile is relatively normal. And we have proceeded with the MRI because one patient has a cognition impairment and another patient has cerebellar signs. So the elder brother showed a focal blooming, likely calcifications involving the dentate nucleus larger on the left with the surrounding gliosis, and gliosis in the bilateral posterior capsuloganglionic region and along the corticospinal tract. The younger brother showed a bilateral symmetric long TR hyperintensity in the region of the dental nuclei, highly of the cerebellum, and moderate cerebellar volume loss. So our clinical diagnosis of cerebrotendinous xanthomatosis is considered, and MRI finding also supported our diagnosis. So we are planning to start the on ursodeoxycholic acid based on the evidence, and we have started physiotherapy, cognition stimulation exercise, and occupational therapy. So my learning points is approach to xanthoma and cerebrotendinous xanthomatosis, and importance of identifying the cerebrotendinous xanthomatosis patient in early age and treating the disease with ursodeoxycholic acid, because it doesn't reverse the sequelae already happened, but it prevents the progression of the disease. Thank you.
Patients are outside. You're not allowed to get them inside. So you can go outside, see both the brothers. They have over the animal media.
That's all. Any questions? Thank you so much for everyone. The gift goes to Lakshmi.